Welcome, everybody, to the Friends of NPACE Podcast. I'm Terry Schmidt, the Executive Director at NPACE and a practicing family nurse practitioner, and I am so excited to introduce today's guest and our topic. Our guest today is Molly Kisiel. Did I say that right?
You did. You got it.
Okay. Molly, you're the Director of Clinical Content for the Association of Cancer Care Centers, better known as ACCC, and you're providing clinical oversight and support for the development of oncology education initiatives, and that's how you came to NPACE. But your background is in breast surgical oncology. You're a nurse practitioner there at Innova Health System, specializing in caring for patients undergoing surgical treatment for breast cancer. Thank you for your work in that area. Your oncology career began as a bedside nurse in adult oncology, followed by pediatric oncology, and later transitioning to oncology nurse navigation to guide patients through diagnosis, treatment, and survivorship, which is interestingly what we're going to talk about a little bit today in regards to what's happening in March. You hold an MSN from George Mason University and a BSN from James Madison University. Did I get all of that right?
You got it. Yeah.
Oh, thank you so much for being here. Welcome to the podcast.
Thanks for having me. Thank you.
Molly, I am so excited that you're here and that we're going to talk about this. And it's just so strange, I find, in doing these and talking to people, how the universe just kind of connects people to what they need. And one of the greatest parts of being at NPACE is getting to meet people like you and talk about what you do. So in season 2, I'm asking everyone we have on the podcast how you got into healthcare.
I mean, I think that a lot of nurses probably say the same thing, that I just always felt like I wanted to help people. But I think the time that I realized that nursing was it was actually when my younger cousin was born premature. He was like 31 weeks or so. And my aunt actually brought me with her to go visit him in the NICU. And that was the first time I saw like up close and personal what nurses do. And I saw not only the way they took care of my cousin, but also the way they took care of my aunt and the rest of my family too. And so that's when I first realized that I definitely wanted to be a nurse. And I think as far as oncology nursing, that came because I mean, I think really everybody has been affected by cancer at one point or another. But I remember my best friend in middle school, her mom was diagnosed with breast cancer. And that was the first time. There had been people around me before who had been diagnosed, but that was the first time that I, again, like seemed much more personal and saw the ripple effects that a cancer diagnosis can have. And so that's what made me really start to put together that nursing and oncology nursing.
I like that. It's so interesting talking to people about the intersection of what brings them into nursing. I love that you were exposed by like going with your aunt. How old were you when that happened?
Yeah. Oh my gosh, probably like 12, maybe 12 or 13. And I think she actually snuck me in because I think you had to be 15 to get in. So we won't get anybody in trouble today, but I think she just knew that it was something that I should do, that I should go see. And she was right, because here I am so many years later.
She changed the trajectory of your life. Interesting.
Yeah, definitely.
So when did you decide to go to nurse practitioner school? Like, what was the push from oncology to do that?
Yeah, I think that, so I had worked clearly in all different areas of oncology. So I started in adult oncology. I always wanted to do pediatric oncology, but I wanted to make sure I could handle cancer in general first before then you take care of kids with cancer. And it was really in pediatric oncology that I was like, how can I do more? I really saw then like the gaps in care, and not from any fault of, the treating providers, but just, I think being a bedside nurse, you just pick up on so many things that, you're spending so much time with those patients, you see the areas where they're missing. And so that's when I really thought, okay, what else can I do? That's when I made the leap into nurse navigation. And it was in nurse navigation that then it's like each step is like building to another step in my career. In nurse navigation, I was able to fill some of those gaps. But again, I just wanted to be able to do more. And that's when I also became more interested in the lead up to the diagnosis and actually taking control and managing these patients' conditions. So whether it be, the actual cancer itself or the side effects from the treatment, or adverse effects, long-term effects, that's when I really decided, okay, there's more that I can do here. How do I do that? And so I went into NP school.
I find a lot of nurse practitioners say that, like they came into healthcare to be clinicians, and the next
Mhm.
logical step was expanding their clinical education and their ability, right, to control the destiny of
Yeah.
their patients.
And it's so funny because I remember being a new nurse and I was like, oh no, I never want to be a nurse practitioner. Like, never. I'm just gonna be a bedside nurse forever. And like I really loved being a bedside nurse. And honestly, there are some times that I do miss some of those aspects of bedside nursing too. But definitely becoming a nurse practitioner was the best thing that I could have done. It was great not only for myself and my career, but I feel like I actually have been able to make a difference in the people that I've taken care of too.
Yeah. Oh no, you definitely have. And you're already impacting the work we're doing here at NPACE. Okay, so I do want to ask how you came to ACCC, but in
Mhm.
that mix in what ACCC is, who they serve, what their mission is, and why that's important.
Yeah. So I'll start with background on ACCC just so that everybody can see how, I transitioned over there. So ACCC, as Terry said, is Association of Cancer Care Centers. And we are really focused on education and advocacy in cancer care. We really pride ourselves on being known as the how-to organization. So not just giving, our membership the information, but showing them how to actually put that in place. So whether it's new treatments, new technologies, yeah, you might hear about it, but then how do you actually get that put into your standards of care? So our membership itself is made up of about 45,000 individual members from over 1,700 cancer institutions. And I think the really unique thing is that we are a mixture. So not only a mixture of different cancer centers, academic, community, private practice, hospital systems, but also our membership is a mixture of the multidisciplinary team. So we have administrators, we have providers, nurses, social work, financial navigators, pharmacists, basically anybody who is involved at any point in the management of cancer care can be a member of ACCC. What brought me to ACCC is, again, we talk about like each step in my career. I'm like, how can I do more? How can I do more? And I've been working in breast surgical oncology for a while, and I really loved the work that I did. I loved being in that patient care. But I started to see like, how can I make more of a difference in overall cancer care? And the organization I worked for are members of ACCC. So I would get the emails all the time and I would kind of see a little bit of what they were doing, but I started paying more attention. And when I saw this opportunity pop up to be director of clinical content, I was like, you know what, let me go for it. Because if I can make any difference in improving health equity in cancer care, then,
Mm.
I will not regret my decision to join. And it's been great. I've been here for just about a year and a half. And I've really enjoyed it's been a little stretch because I've had to go back into all oncology versus just breast specific. But it's been great. It's just like such an exciting time to be involved in the oncology world with all of the advancements. So being able to be a part of that and helping those to get put into place has been really exciting and really rewarding for me.
Well, I appreciate you sharing your journey, and I love that each step has just expanded your ability to improve power and patient outcomes. I think that's why we're all practicing. Um,
Hmm.
I have to tell you though, as a family practice primary care clinician, when anyone says the word oncology, and this was my fear from the beginning, even with what we're doing, I like shut down. I'm like, that's not me. I don't want to know the meds.
Hmm.
I don't want to know the labs. It's like when I have a pregnant patient, everything goes to
Yes.
OBGYN. The oncology patients are the same way. And I know I
Hmm.
cannot be the only primary care clinician that feels that way. They just send everything.
Hmm.
So tell me a little bit about what you're seeing in knowledge of primary care clinicians or
Hmm.
areas that they need to know about in sending patients what we're missing and maybe addressing some of that fear, because I'm seeing more and more patients who I'm having to manage while also in oncology, because oncology just does not have the bandwidth to do everything,
No.
or they're coming back to me. And frankly, it all
Hmm.
terrifies me.
Yeah. That I feel like is such a common thing that I saw definitely when I was still in practice. As soon as it was anything like breast cancer, they have breast pain. Oh my gosh, go right back to the oncologist.
Yes.
And like you said, there's a shortage of oncologists. I mean, I think that's seen throughout so many fields in healthcare. And so really we need to empower, our primary care providers to have the confidence in managing those patients, because then the patients will also have the confidence to be with their primary care provider. But I think really what it comes down to, primary care providers are that front line. They're the first ones to identify the symptoms, the risk factors, the ones to make sure that patients are getting their screenings and making sure they're getting their mammogram and their colonoscopy or going for their prostate check. And I think when you think of us more as a team, cancer just goes beyond the specialty. We're all part of the team and making sure that the patients have the best possible outcomes. But primary care especially plays a huge role in that early detection, survivorship, and then the management of comorbidities too. Because of course, their underlying conditions aren't going to just disappear during cancer treatment. So we need to make sure they're still being taken care of for their cardiovascular health, any other conditions they're being treated for. And along with that, it's like the interaction of medications too, that we need to work as a team and make sure that we're able to still treat them for their underlying conditions while, trying to get rid of their cancer as well. And so I think it's just like, I can't even name all the areas because there's so many that we should work together on. But I think if you want to focus on the screening, so making sure our patients are getting the appropriate screenings, and then that care coordination, so having the good relationship with an oncology provider to make sure that your patients are getting in, and then staying involved, so making sure that you are that teammate throughout their treatment, so that way at the end in survivorship care, everybody, the primary care provider, the oncologist, and the patient are comfortable being managed for the most part by the primary care. So with that being said, I think there are crucial points, of course, that the patient would need to go back to the oncologist. And that's what I'm really excited for the conference in March to talk about. So, when it's okay for you to hold on to them and when this is a patient that should definitely be sent. But I think the other thing is just, along with having that care coordination, the team playing, we are a team. So, we can all talk to each other, and you can always call up the office and say, hey, I'm not so sure with this patient. They're complaining of this. Is this something they need to be seen for? I know that might sound like, oh, I don't want to take the time out of their day, but if it's something that then we can save the patient from making a trip to the oncologist and they can still be managed in their local, facility, then we've done everybody a favor.
No, I really like that. I think that's a really good point. Wendy Vogel said almost the same thing, like you just need an oncologist friend. She's like, I need a family practice friend and you need an oncologist friend to ask questions to on the side. But I think it's really important, and there's so much fragmentation, and maybe you can speak to this a little bit more from when you were navigating, coordinating care. There's so much fragmentation in the system that patients don't always trust all of their clinicians to talk to each other. Right. It's so hard even to get records. And so for a primary care clinician to say, don't worry, I'm going to call your oncologist about this and talk to them, and to know that there's this kind of team approach, I think would go a long way with patients who already struggle in a system of prior authorizations and who do I call? Who my insurance?
One other burden off. Yeah.
Yes. Yeah, that thing.
Yeah.
You mentioned screening, which we are going to talk about. I am interested in the handoff and the survivorship piece. I know we're going to talk about that a little bit, but you helped in this care coordination navigation. How was that piece to send someone back to primary care? Did they separate from oncology? What was that like?
Yeah, I think that, there are so many aspects that go into having like a successful transition back to primary care for the management of most of their needs. And I think really it's not just on the primary care provider, it's also on the oncologist to set that confidence for the patient and being like, you are doing well. Here are the signs that you should look for also, but otherwise your primary care provider is fine. I find the patients that you actually spent time educating and talking to them and alleviating some of those concerns, knowing that we're still here too. That was something I would always tell them, like, you do not have to come back, but I'm here. So if you need to, I'm still here. And I think giving them that reassurance that you are good, you can be managed in the with your primary care provider. That's your person. They know when to call me, but you also know when to call me. I think that's what would make it more successful. And those tended to be the patients that didn't come back to me because I let them know, like, I'm not disappearing. I'm still here. Like, you can still come see me anytime, but your provider can also call me anytime. And so I think it was just like that comfort, like knowing I'm still in their back pocket somehow.
Yeah.
Like that, helped them to then move into that survivorship world.
Nice. We're going to talk about care coordination a little bit. And so besides moving back to primary care, it's that initial, when I get something suspect on a test, and then the next step is usually oncology. As a primary care clinician, what am I doing wrong or maybe not helping oncology with? Like, do I just let them go? What should I send? What are the pain points there for oncology?
No,
when primary care is just
that's
like,
a great question. And I'm sure it of course, I'm sure varies by the disease type as well. And so I'm going to step into my breast surgical oncology role to answer that. And most breast cancer patients will see the surgeon first. So that's typically their first step. So we would get the patients typically from the primary care provider. And I would say the ones that I saw have a really great transition are ones where if they couldn't be seen right away, we always tried to get new patients in within honestly 3 business days. But if they couldn't, and so there's gonna be sitting there waiting, having the primary care provider reach out to maybe not even the physician or the NP, but maybe even the navigator within the office or, the new patient coordinator and asking, okay, this patient's very anxious. What can I do? Is there anything I can do to help expedite? So from my practice setting, typically they would see the surgeon, and then the surgeon oftentimes would order a breast MRI. So that's another thing. Then they're going to have to wait, and they're going to have to wait to get those results, and they have to talk to the surgeon again. So that was something that was so incredibly helpful and could expedite a patient's care, is if the primary care provider reached out and they would order the breast MRI, and we would tell them exactly what to put in there, what to order. But because we hadn't seen the patient, we didn't want to order it ahead of time, but they could, and then we would have those results, and then maybe they can get set up right for surgery instead of having to go for another appointment afterwards. So I think, again, it all just comes down to not being afraid to, communicate between the two teams too. I said we're all the same team, but you know what I mean.
No, right.
To communicate across,
all the patients team.
and just reaching out. That. Yeah.
So calling
the
and
office,
I think if you can't talk to whoever, does every oncology office have a patient navigator?
No, but ideally, yes. But there's always at least somebody, even honestly, people who are scheduling the appointment. So they honestly are new patient coordinator. Again, I was lucky to work at a health system that had plenty of resources. And so we had a new patient coordinator and we had nurse navigators. But our new patient coordinator is not clinical, and she just knew from collecting all the records to get those set up for the physician, the things that they would need. So sometimes the new patient coordinator would just come knock on my door and she'd be like, Molly, what do you think this patient needs? Because she's not going to be able to be seen for 2 weeks. And so I would tell her, oh, okay, tell them that they should order a breast MRI. So again, you're not even necessarily that was no part of my day at all that they took to ask me that question, but it helps to expedite. And if you're putting yourself in the patient's shoes, it's sitting and waiting, knowing that there's suspicion or waiting to find out or get this out of me. It's they need something to do. So if we're able to give them something to do, then that's great. And then they don't have to wait as long after.
How much trust would we build doing that? Oh, I got to do that as a primary care. I called the office and I know it's going to be XYZ days to get in, but here's what they said I could do to help. Let's order this. Let's order this. We're going to go ahead and get this rolling. Go ahead and make your appointment. Yeah. Okay.
I think the other thing as a primary care provider, if you're not comfortable ordering the test, or sometimes the patient is no, please don't. I'll just wait.
Gotcha.
I think also telling them, that again, you're still there for them because you're their person. You're the person they trust. They don't know us yet. So knowing that you're still there, but also number one thing, tell them not to Google. Don't Google anything, because sometimes they're waiting for that first appointment and they're just, like I said, they need something to do. So they're going to jump on Google and try to find whatever they can. And I do believe that knowledge is power. So I don't think it's telling them just don't look it up, but it's giving them the right resources. So telling them what are the good websites to look at. Don't just go on and look at these random blogs, or places that don't have necessarily evidence-based information. So really giving them those tools too, I think is really helpful. So those patients will come in educated to their first appointment, but without some of those, things that they maybe shouldn't be reading about.
Okay. No, that's all incredibly helpful. I know when we meet in March, we're going to talk about things like screening patients who've already had cancer or who's at high risk. We're going to talk about the genetics interplay, which I'm not sure all primary care people understand. Like if you only get one shot at genetic screening in your entire insurance lifespan, who should be doing that and how do we doing that? Co-managing those things like comorbids and medications. All of those are such important pieces for primary care to understand. But that initial handoff and taking people back into the fold and just working with them, I think is really, really important to understand. Thank you.
You're welcome.
So you came to NPACE through ACCC and you actually helped advise us. So I just love to hear a little bit about what you're thinking about the March Virtual, why it was important to ACCC in the first place, and what you hope that primary care clinicians get out of this.
Yeah. So I think, working in this oncology specific field, we hear so much from our members just about the need to really educate the primary care provider so that they are comfortable in managing, especially some of these immunotherapies that have, immunotherapy related adverse events. And these are patients that are maybe treated far from their homes. And so we really need to make sure that their primary care providers who are closer to them are comfortable, and knowledgeable in managing some of those things. So that's one big thing we've heard from our membership. So when we heard about this conference, we were like, oh, this is what our membership has basically been asking for. But I think also it's just, as treatments are improving, people are living longer. We're surviving cancer, which is great. But then there's so many more cancer survivors to manage and those possible long-term effects too. And there's just no way that they can stay in the oncology clinic forever, because we also, as surviving rates, people are surviving more people are also being diagnosed. We're seeing those trends as well. So, we need to make sure that, like I said, we're just moving people along, knowing that we're available, but, able to be comfortably managed by their primary care provider as well. And I think the other great thing with being involved with the planning for this is that we have so many ACCC members who are experts, not only disease specific, but, in psychosocial aspects of cancer care and financial toxicity. And so it's really great to be able to share our experts, our members, with, a broader community and get their knowledge out there, because they're great.
I agree. I'm so glad you guys are here because I'm clearly not the expert. And I knew we needed this, as a past faculty member and an administrator for a family nurse practitioner program. We're not teaching this stuff in school anywhere. We teach who should be screened in what age and the U.S. Preventative Services Task Force guidelines to pass certification exam. But beyond that, we're not. So I really think this content
that's actually a really interesting point, because we actually, as part of ACCC, we also have several oncology state societies, and we have several that are actually doing a program on basically how to use the APP in oncology care. Because just like you said, I'm a family nurse practitioner by background. I went into oncology because that's my background. I worked in oncology for years as a nurse and as a navigator, so I had that foundation. But for people who don't have that foundational knowledge, maybe people worked, general med surg or some other specialty and then want to branch into oncology nursing as an APP, how do you actually get trained up in that? So that's something that we are also continuing to work on. So again, it's like all these little overlaps here on how to really improve cancer care.
Yep. APPs are so critical in providing a lot of care right now, especially in access areas, right? And so I love that you guys are doing that. I do think there needs to be more of that, but we have got to be training the primary care clinicians to out of the gate on how to do this.
Right.
I'm excited that we've started this partnership, and I hope that we keep in touch with ACCC even beyond what's going to happen in the March Virtual. The beauty of that is anybody from anywhere can go, and it's recorded, and you have access for 90 days.
Right.
But we just need, as more people are diagnosed and more people are living longer, as you pointed out, we have got to have some specialists that can help us in all of this. Any parting thoughts that you want to share with the audience?
No, I'm just really excited for the March conference. And I think, just emphasizing what we've been saying, that, we're a team, we're partners, and that really anything that we can do to improve patients' journey through most likely the most difficult time of their lives is a good thing. So, if we can work together and figure out a way to, mend those gaps in care and make sure that patients are comfortable, the oncologist is comfortable, and the primary care provider is comfortable, then, things can only improve from there.
Agreed. Well said. For anyone that's listening, for all the listeners, you can find a page. We have a page at NPACE. If you go to our March virtual conference, we have a partner page, and you can find more about ACCC and AppShow there. But Molly, what is the website URL for ACCC if people are interested in finding? Because you guys do continuing education as well.
Yeah. So our website is www.accc-cancer.org.
Nice. Very good. I love it.
Actually, I don't think you need to put the www dot. I think you can just do accc-cancer.org. But
some of us still need that.
The World Wide Web. Yes.
Yeah. Oh, this has been great. Molly, thank you so much. I'm so excited about what's going to happen with the March virtual. NPACE is super excited to work with ACCC and AppShow. And thank you for being with us and for continuing to practice in this area. It's a big deal.
Thank you.
For our audience, be sure to check out all things NPACE at npace.org for information. You can find stuff about the March virtual. We're actually going to run a special and package that with all the other virtual conferences, so you have access to everything this year. But we also have on demand. So once the March virtual is recorded, give us a little bit of time and we will turn it around. And you can get it on demand at learn.npace.org. NPACE is an ACCC accredited provider of continuing education, offering in-person CE and live virtual and online programs for all APPs now. We have CME and CE credit for our events, and you're welcome to check us out. Thank you, Molly, for being here. I appreciate it.
Thanks for having me.
Bye, everybody.